It is now the turn of our colleague from the States, Professor Suzanne Freitag, that will talk about new insight and result of Teprotumumab treatment in Graves' orbitopathy. Suzanne, please.
Hi, I'm Suzanne Freitag. Thank you so much for the invitation to talk to you today about Teprotumumab. These are my financial disclosures, and Horizon Therapeutics is the manufacturer of Teprotumumab. So these are some of the many faces of thyroid eye disease, and these are moderately severe cases in my practice. And as you can see, this is a very devastating disease, both physically and psychologically for our patients. And we've been challenged since the beginning of time on how to manage these patients. Unfortunately, we had a big breakthrough in January 2020 with our treatment options, and that is because of Teprotumumab. So this is the first and only US Food and Drug Administration approved drug for thyroid eye disease. It's a fully human monoclonal antibody. It inhibits insulin-like growth factor 1 receptor. It's for the treatment of moderate to severe thyroid eye disease and has very broad FDA approval indications. The mechanism of this drug is as follows. Overexpression of the IGF-1 receptor is a known key pathological feature of thyroid eye disease. The IGF-1 receptor interacts with TSH receptor, leading to the inflammatory cascade that we're familiar with. Teprotumumab binds to the IGF-1 receptor and inhibits this cascade. It's an intravenous drug infused every 3 weeks for 8 doses. The biggest logistical issues are that the drug is very expensive and it requires insurance authorization, which can be very challenging. Also, it requires arranging an infusion site or home infusion for these patients. The phase 2 and 3 clinical trials were published in the New England Journal of Medicine, and the setup and the outcomes are quite similar. So I'm going to skip to the phase 3 clinical trial and very briefly go through the results. 41 patients were receiving the drug and 42 received placebo. These are the outcome measures. The darker black line is drug. The gray line is the control group. So you can see there was a significant response for the following: proptosis response, change from baseline in proptosis, diplopia response, reaching a clinical activity score of 0 or 1, overall response, and change in baseline in quality of life. The contraindications to this medication are pregnancy, breastfeeding, and in children less than 18 years of age. A relative contraindication is inflammatory bowel disease like Crohn's disease or ulcerative colitis. We use it with caution in people with diabetes. It drives up the sugars in diabetics and pre-diabetics, but they can be managed with increased doses of their medications. So let's look at this in the real world. So the real world right now is just the United States where the drug is available. And I'm one of the largest prescribers of this drug and have a good clinical group of patients receiving this. I prescribe and manage the drug myself. I don't rely on a rheumatologist or endocrinologist or other physician to prescribe and manage. Before the first dose of medicine, we get a serum glucose and hemoglobin A1C because of the risk of elevating blood sugars. We also get an audiology baseline test. These receptors are present in the ear, and we'll talk about ear changes in a moment in these patients. And then just before each infusion, we do a quick finger stick glucose and a urine pregnancy test if relevant. The clinical trials included patients only with active thyroid eye disease, and no patients in the trial were treated for compressive optic neuropathy. Currently, in my experience and in published cases, there is utility with this drug in compressive optic neuropathy due to thyroid eye disease and chronic thyroid eye disease. I'd like to present a couple of patient examples showing some different clinical scenarios. The first is a 68-year-old woman with hyperacute new onset thyroid eye disease. She was a recent smoker. She had restricted movements in both eyes with double vision, a clinical activity score of 10 out of 10, Hertel measurements of 30 and 31, and compressive optic neuropathy with inferior visual field defects in both eyes. Here is her picture straight on and in the various directions of gaze. You can see she has an incredible amount of edema and erythema of her ocular surface and her eyelids. She's very uncomfortable. Here she is after 2 of 8 teprotumumab doses. Hertel measurements went from 30-31 to 23 and 26. Her optic neuropathy has completely resolved. Her clinical activity score was 2 out of 10. Those points were just for her pain and pain with eye movement. You can see the external signs of inflammation all look so much better. And here she is side by side before and after 2 doses. And here is CT imaging before treatment. You can see she has very enlarged extraocular muscles on both sides. And on the bottom left, you can see that her orbital apex is crowded by these large muscles. And then after 8 doses, you can see that the muscles, although slightly enlarged, are very significantly improved, and her orbital apex is not crowded. So this is a different patient. She's 55. She has new onset active thyroid eye disease, but a very different phenotype. When you push on her globes, there's significant resistance to retropulsion. Her orbits are just totally inflamed and hard, and she's having a lot of pain and feels absolutely miserable. After 4 doses, she came in saying, "I feel and look like myself again." And here she is after 8 doses. So for her, this was sort of a factory reset back to her normal baseline. Next, I'd like to show a 72-year-old man. He was diagnosed by multiple physicians as having allergies. And he came to see me, and I was suspicious for thyroid eye disease. He was proptotic, 28 and 27. He had restricted eye movements in both sides, things that are not really consistent with allergy. And his thyroid functions and antibodies were abnormal, consistent with Graves' disease. So I met him prior to the FDA approval of teprotumumab. So he was initially treated with 12 doses of IV steroid, didn't help, got rituximab 3 doses, really didn't make any difference either. And then he got teprotumumab, and you can see that his festoons of lower lid edema are shrinking up. His proptosis is reduced several millimeters, 24 and 24 after 3 doses. Now, he's definitely going to still need some lower eyelid surgery, but we're putting out the fire finally for him. When deciding on thyroid eye disease treatments, it's important to understand what the different treatments will do. Each treats a different constellation of findings. And so I've made a list of common signs and symptoms, and I've used a traffic light coloring. So green means that these things are likely to be fixed. Yellow means maybe fixed, and red is not going to be fixed by the various treatments. So this slide is looking at steroid. So if we're giving steroid to a patient with thyroid eye disease, I would expect their active inflammation to get better, their pain, the conjunctival and eyelid changes. They might have an improvement in their eye movements. They might have an improvement in lid retraction. They may have a reduction in their eye pressure, and their compressive optic neuropathy may be helped. I don't expect it to melt the fat, the roof hypertrophy, the steatoblepharon, the proptosis. I would not really expect steroid to fix that. So let's look at this same list for teprotumumab. It is not good at fixing upper eyelid retraction. It can help, but I tell patients you may still need to have your upper eyelids fixed, and sometimes lowers as well. It's a mixed bag for fixing double vision. For people who have mild restriction of eye movement, it can fix that. For people who have an eye that's stuck down or in, it's not likely to completely resolve that. It is likely to decrease the extraocular muscle size. We're finding that in almost all of our patients when we do CAT scans on them. So it's helpful to know what your treatment is going to be expected to do so you can tailor it to your patients. So what about chronic thyroid eye disease? This is a patient of mine who had severe disease and then has been inactive for about 4 years. She underwent multiple eyelid surgeries because her eyes were prolapsing in front of her lids, but she did not have an orbital decompression because she was worried about double vision. So pre-treatment, she was 28 millimeters on her TEL, and after 2 treatments, she's at 24.5 and 25. You can see that the upper eyelid ridge of fat is melting away. And she says when she feels her eyelids and when she pushes on her globes, everything is much softer. And I agree. So what about adverse reactions? I just recently calculated in my own patients the reactions, and I think it's very similar to what was published in the clinical trials. So in my patients, 96% reported adverse reactions as mild or tolerable, and a lot of these patients really had no adverse reactions. 55% did have muscle spasms, usually in the calves of the legs. 36% complained of ear changes. Now, the most common ear changes are a mild buzzing or tinnitus, sometimes in one ear, not both, and sometimes unilateral or bilateral muffled hearing, like getting off an airplane or having some pool water in your ears. I've had 3 or 4 patients who've had some pre-existing sensory neural hearing loss, which they feel did get a little worse on the treatment. We've stopped the treatment in one patient and are considering stopping in another because of concern about her hearing. About a third of the patients complain of nausea and fatigue. Some have a change in taste. Some of the younger women have diarrhea. I've got a few people with brittle nails, and about 8% of my patients were diabetic or pre-diabetic, and their sugars did go up. In conclusion, Teprotumumab is a powerful addition to my armamentarium of thyroid eye disease treatments. It's effective in moderate and severe thyroid eye disease, and very few patients are non-responders. It can be rapidly effective in acute thyroid eye disease and effective in quickly reversing compressive optic neuropathy. It can be effective in chronic thyroid eye disease even years after the acute phase. Radiographically, it reduces extraocular muscle size and proptosis, and clinically reduces proptosis and periorbital eyelid fat. We used to tell patients with moderate to severe thyroid eye disease that they should expect that they would never look the same again. For many patients, this is no longer true. Thank you.
Thank you, Suzanne. Very nice talk, and very much looking forward to have this drug also in Europe in a way to help better our patient. I just look at the question and answer, and there is some question concerning the clinical significance of the diagnosis of IgG4 associated with Graves' orbitopathy. So eventually Marta or Katerina can answer. So when you suspect a possible association, since it is, let's say, important clinically to be able to use rituximab, for instance, instead glucocorticoids alone, do you, at this stage, do you advise to take a biopsy, possibly of the muscles or of the tissue that can be involved, like the lacrimal gland?
Maybe I'll start. So I would not do a biopsy of the muscle because it's more invasive. But of course, if I see an enlarged lacrimal gland and I do eyelid or decompression surgery, then of course I would do the biopsy. But the more easy thing is to test the IgG4 in the serum. And we do this now quite in the daily routine, especially when the case is not completely normal. So maybe Marta can add something.
I agree.
Okay.
And
well,
I think that if you are not...
Please, Marta, please.
I was just going to say the same, that if you're planning surgery and the clinical course is not typical, then it's easy to take a biopsy. But if a patient has all the, I mean, if you're thinking that it may be an IgG4 because it has something different, and also the levels in serum, as Katharina said, are high, then it should as you said, it should be necessary a biopsy, and probably from the lacrimal gland, which is more easy to take.
Right. Well, a few years ago, when we start talking about orbital IgG4, I still remember I received one paper from some friends from Australia, where it was said that in the case of monolateral orbital disease, well, you don't have a systemic one, therefore it was not possible to find alteration in the blood. While in the case of bilateral IgG4 orbital disease, you might find also alteration in the blood. You can have a rise titer of IgG4 in the blood. Did you have any experience of suspect Graves' orbitopathy and IgG4 disease monolateral?
No, we don't have, because I have had several patients with both diseases or an associated disease, but as far as I remember, no monolateral diseases. What I see more often is patients having IgG4 related serum markers, but rather atypical orbital disease when they have additional Graves' disease. So they don't really have an orbitopathy like disease with eyelid retraction, for example, but only the typical signs of IgG4 disease associated with Graves' disease.
Okay, thank you, Katerina. I saw also some other question for the second talk, the one on Teprotumumab. And one recurrent question is about autotoxicity. Suzanne, can you tell us more about this complication? Which is the frequency of such a complication in your practice?
Sure. My adverse effects slide was the data from my practice. So we had about 36% of patients with ear complaints. But the vast majority of those complaints were not sensory neural hearing loss. So the vast majority of patients have a buzzing in one or both ears, described as similar to tinnitus. And some of them also have a clogging or muffling of the sound, which is different than a hearing loss, but more like if your ear needs to pop after being on an airplane. And that is an intermittent finding. Some people say it's more common first thing in the morning and gets better during the day, but it's not something that's always present in these patients. And we know that the IGF-1 receptors are present in the ear. And so it would make sense physiologically that the medication could be affecting these receptors as well. Now, we have a few patients who had some baseline sensory neural hearing loss on their audiology testing, which they were aware of as well. And these patients have gotten worse during the course of their treatment. One of them got a lot worse, and so her treatment was stopped. I'm fighting with another patient right now whose hearing is clearly worse, but she doesn't care. She's so happy that her eyes are getting back to normal that she wants to continue with the drug. So that's a whole nother level of ethical discussion. But we are having serious conversations with our patients with existing sensory neural hearing loss. And in fact, I just turned away 2 patients recently who agreed with me that they did not want to risk further sensory neural hearing loss. And so a lot more will be discovered about this as we look at our audiology testing data, and other centers are also doing the same.
Okay. And now a question of mine, the effect of Teprotumumab, either the side effect like hearing loss, but also the positive effect like exophthalmos reduction or increased eye motility and inflammation, are lasting long, or they are somewhat reversible? They last for a while, but then there is a recurrence of disease. So in
So
other words, sorry. I was
sure. So I currently have 120 patients enrolled for the drug. Most of them have started their treatments. Many of them have finished their treatments. I am retreating right now one patient out of my patient population. She did very well. So she was a hyperacute patient, sort of like the first patient I presented. Her double vision and her optic neuropathy resolved with 1 or 2 doses of the drug. She completed 8 treatments. She did great. She felt great, but she still had upper lid retraction. So we waited 7 months after her treatment was completed. She was absolutely stable. And at 7 months after treatment, I did upper lid recessions internally, and I did blepharoplasty of the upper lids. And for the first 2 months after this upper lid surgery, her disease reactivated. It reactivated to the point that her lids were swollen and inflamed, her conjunctiva was inflamed, her double vision came back. So she was able to get retreated. She's had 2 doses now, and she once again has had a rapid resolution of her reactivation. So I have to wonder, given the timeline, if my surgery may have set her off. And if that's the case, should we adopt a different way of thinking about doing surgery before we were waiting as long as possible for these eyelid surgeries after disease deactivated? And now I'm wondering if we should do our surgery sooner while we still have drug on board. So there are a lot of questions to still be answered, but I'm moving toward earlier surgery for my patients now for their upper lids.
Thank you, Suzanne. I think that Christoph wants to ask you a question. Please, Christoph.
Oh, thank you. Susan, yes, the cases you presented, they were absolutely, yes, amazing. And we all know that the earlier usually we treat, and that's with the steroids the same, we're treating active disease. What I just couldn't understand, how would you explain an effect in long-standing chronic cases with this drug?
I think we may have to redefine what we're calling chronic. Maybe chronic patients they're chronic from a timeline perspective, but maybe chronic doesn't mean inactive. Clearly, however this drug is working, there's still something going on in order for these patients to get better. So, and it's not only good at putting out the fire of the inflammation, but it has a remarkable ability to shrink fat. And I think that's one of the biggest differences between this drug and our traditional anti-inflammatory therapies like steroid or the other immune modulators. They're good at putting out the fire in many patients, but the roof hypertrophy and the fat pads in the upper and lower lids just don't shrink up in the same way they do with this drug. So I think, it's a very different mechanism, but I think that we have to wonder, is it working on this other fat mechanism, or is there still actively inflamed tissue in what we're defining as chronic thyroid eye disease? I think we need to be careful about how we use these words now. And I think we're going to have a little different paradigm of thinking about this disease activity as we learn more.
Thank you very much. And I